Welcome to this wonderful next Wednesday evening. Beautiful night to record here, June. Excited to be with you. We are going to be talking about an issue that, I don't have a ton of exposure to, but something I care a lot about. My mother was an art teacher for decades, and she did a career change throughout her life, switching from fashion into the world of, teaching art, for kids. Gave me the inspiration to make a career change myself from finance into medicine. And so quick shout out to my mom. But one thing my mother also used to tell me a lot about how she would notice significant changing in the emotional health of her students. And she worked for 20 something years that she noticed a pretty drastic difference. So of course, this is anecdotal evidence, right? Like this is my mother, but made me really scared. So what we're going to be talking about tonight is, maybe a potential solution, maybe a potential arguably harm at times, but what are you going to tell us about?
So the idea for this episode actually came to us because you guys, the audience, you guys have been reaching out to us, giving us your feedback. Appreciate that very much, by the way. And keep sending us those emails and,
Absolutely.
leave comments. We read all of them. So this actually came from an Instagram comment. I think it was more meant to be like kind of an offhanded comment, but one of them said,
if you hate our stuff, please comment. Whatever.
Hey,
we can take
we
it.
welcome the hate.
We got thick skin. We work in psych wards. You know the shit that we've heard.
Oh man, sometimes patients will say, they'll say some crazy things.
Yeah, we'll be
you gotta
all right.
have thick skin to work in this industry.
You do.
So basically that comment said, they're screening for depression in 12-year-olds.
Mm-hmm.
So the fact is, that is not true. It hasn't happened yet, but there is a push for it.
Maybe is happening though some places though.
It's starting.
Nowhere.
Yeah,
right.
It's getting more and more momentum. It's gaining more and more support. And I can see why some people are going to be concerned about that. And to be honest, I myself have some reservations about it. So today we're going to be discussing all about these screening recommendations that the USPSTF, the U.S. Preventive Services Task Force, is putting out there. So I went to their website and I pulled off their recommendation. And I'm going to read this to you, Logan, and I want your reaction. So it says this. The U.S. Preventive Services Task Force concludes with moderate certainty that screening for MDD, major depressive disorder, in adolescents aged 12 to 18 years old has a moderate net benefit. So I read that and hey, it's 2023. Mm-hmm. It's the age where language is very important. Mm-hmm. And I was like, moderate certainty, that it may have moderate net benefit? I don't know. It just comes off as very non-committal to me. I feel like if you're going to recommend that we make this kind of change, if you're recommending that all schools in the United States need to screen for depression, you gotta speak with a little bit more certainty. So this kind of seems like, when we kind of make a soft recommendation, like, hey, this may potentially benefit at a very low dose. So like, what do you make of that, Logan?
I mean, I honestly kind of disagree with you there, just because I feel like a lot of these recommendation bodies, these organizations, we did a fantastic review of the Cochrane review, talking mostly about non-pharmacological interventions for the spread of upper acute respiratory disease, COVID, and talking about how, masks, whether they actually had an effect. I feel like that's just kind of standardized language that a lot of these scientific articles use, very infrequently. I don't have those numbers, but I feel like very infrequently they'll say this is a extremely strong recommendation with high certainty evidence. Like, I feel like it's just kind of like the typical language, because when we study these things, there is always uncertainty. We can make educated guesses, but we as physicians never know anything with 100% certainty. So when I hear that moderate net benefit, moderate certainty, I'm like, well, it's better than low net benefit and low confidence, So I'm kind of like, all right, I'll listen.
All right. I moderately agree with you there.
With low confidence.
Yeah, low confidence. All right. So just to preface this conversation, so the recommendation is only for adolescents aged 12 to 18. They actually said, so they actually did not recommend in children 11 years and younger because the evidence is inconclusive. Mm-hmm. So they didn't not recommend it. They're just saying there's not enough evidence to there's not enough evidence out there to really conclude if they should make the recommendation or if they shouldn't make the recommendation. Okay, so this discussion basically is going to circle around screening for depression in adolescents aged 12 to 18. So let's talk about why it's important to potentially screen patients, at a very, very young age, right? And the major reason for that I can think of is the importance of treating depression, right? You have to be able to identify it in order to treat it. So actually in adolescence, depression is the leading cause of disability in the US for that age demographic. Number two, untreated depression, it can lead to developmental trajectories that are negatively affected. And especially when we talk about somebody, that's as young as 12, ranging all the way to 18, that kind of developmental trajectory affection can mean that they don't go to a good college. They might not even go to a college at all. So it can have significant downstream effects, right, in terms of the quality of life that they're able to attain and live. Number three, suicide is the second highest cause of death in patients 10 to 19.
Scary.
So obviously we know depression is highly correlated with suicide, and anything that we can do to save a life from completing suicide is action that we undoubtedly must take. And last, MDD in adolescence is correlated with recurrent MDD later on in life. So if you have untreated depression as a teenager, it's very likely that that issue is going to persist into your adulthood, and it may even progress to the point where you're having suicidal thoughts. It may be complicated by other mental health disorders such as anxiety as well. Right. So these are the possible, these are the potential benefits of screening. Is there anything that I'm missing there, Logan? Anything you can think of?
Well, I guess, one, I want to ask about the study the USP Preventive Task Force, but then your own clinical opinions. And so when it says screening, is this screening by a pen and paper? Is this screening in a physician's office, at school? Is this something that the parents give to their kids? Like, screening is so, what does it specifically mean here?
The way it was written, and my understanding of it, is that the symptoms are going to be reported by parents or caretakers.
Oh, not the patients themselves.
Not the patients themselves.
Okay.
Potentially it could be. I mean, maybe there's going to be a second round of screening, but the primary screening is going to be geared towards more the caretakers.
What do you think about that?
I'm kind of conflicted, because we certainly, don't want to dismiss the concerns of that individual, right, of the patient themselves. But at the same time, at a young age, you may not necessarily know how to phrase some of your, some of the struggles that you're going through. You may not even know what it is. And also there can be potential complications or potential societal pressures or familial pressures that cause them to underreport or not report symptoms at all. But yeah, I see your concern, and I definitely share with you in that. I think for the most part, we're very used to treating adult populations, and we're very used to caring for patient autonomy, right? The way medicine is delivered today is all about the patient first. Our job as physicians is to provide them with the risks and the risk versus the benefit analysis, and to allow that person to make the best possible decision for their unique circumstances. So when we say we're not going to ask the patient directly, but we're going to ask somebody else in their place, even though that patient is perfectly healthy, they're not incapacitated in any way, I definitely see your concern there. But I will also ask you to remember that when we're doing cases in the ED, right, we have a suicidal patient who's under 18, all their decision is made by the parent, right? Whether they want to be discharged, whether they're agreeable to going to an inpatient psychiatric hospital, right? It doesn't matter what the kid wants. Ultimately, it's going to be what the parents want.
Yeah, fair. For the most part, sadly, I think we both have been involved in those cases where, the parent is advocating for some certain thing, and, we have had to involuntarily put a patient into a pediatric patient, right? It's not a fun process for anybody involved. I guess what I'm referring to here is, if we're rescreening these people, I think, I completely agree. I think we should absolutely talk to the caretakers, the teachers, the parents. But I do think it's important to even screen that patient themselves, especially if we're starting at the age of 12. I like to, when I interact with these patients, and I'm by no means a child and adolescent psychiatrist, but, we do have to cover these patients all the time in the emergency room setting, also in our, the kid unit that we work at. I like to talk to a fifth grader, like, you know what? I'm going to try to at least talk to you as much as I can like an adult. Like, not everything that you tell me right now is something that I have to go share with mom and dad. If there are, of course, concerns with safety, then I'm compelled to. But, like, have that physician patient trust and relationship. So, I value that, and I know you do too. And so that's why I think when we advocate for these screening things, at least I am, you even said it, like, the number one cause of harm and death in this patient population is self-harm and suicide, right? So that's why I want to talk to the patient, screen that patient directly. I want to get input, of course, from the teachers and everything too, but how can we collect as much data as possible to avoid a suicide?
All those are very fair points, and certainly there's nuances to these screening methods, and certainly as time goes on, especially if it is going to be implemented on a wide scale basis, there does need to be conversations such as that, like what exactly is the final screening going to look like.
Right.
But on the idea of possibly screening junior high school students for depression within school systems, what is your initial feeling about that? Because people are divided on this. It's a controversial topic. Some people hate it, but some people say it's a great idea. Where do you land on that?
Man, I mean, it's almost like shocking for me to hear that maybe some people would view this as controversial, because I almost feel like I'm so on one extreme of, yeah, why wouldn't we screen? Because these high school kids, middle-aged kids do achieve suicide. They do engage in self-cutting. Like, I would, if someone disagrees with that, I would say, give me one reason, in the face of a potential death, why we shouldn't at least bring this up.
So one potential reason is that there's a concern that children in the United States are being over-medicated. There's been a sharp increase in the diagnoses of ADHD, depression, and all other types of psychiatric issues within the pediatric population. And I don't think, especially after going through the COVID pandemic, I don't think we can deny that certain industries, I'm talking about the pharmaceutical industry,
Right.
of course, they have a financial incentive to place people on medication. And especially here in the United States, I feel like patients are especially vulnerable to potentially some of the greed of the pharmaceutical industries, because after all, we're only one of two nations worldwide where pharmaceutical companies can advertise directly to the consumers.
Mm.
Like, that's ridiculous. And we know that pharmaceutical companies they fund a lot of money to lobbying groups, and they have a lot of power even within our media, right? A lot of their revenue, the media ad revenue, is being funded by the pharmaceutical industry. So I don't think we can ignore or even deny the fact that that is an extremely powerful organization, and their incentive 100% is, I would argue, is never the well-being of somebody, but is their bottom line profit.
Yeah, sadly, I mean, I don't disagree with you there, right? But I think I mean, yes, more screening, more people who would be diagnosed with depression, of course, could potentially be started on SSRI, or, well, I shouldn't necessarily say SSRI therapy, but it would probably be most likely that, right? Or just, we'll call it any antidepressants. I don't disagree with you there. But when someone is screened for something, our first line treatment should not be medicine, right? It really should be, especially for like depression and self-harm, is getting that person to engage in some kind of therapy, right? But I also think, like, I get really frustrated with the rigid system of therapy. Why does it always have to be something, in a sense, kind of boring? I have encountered some child programs that actually had like equestrian therapy, recreation therapy, art therapy, music therapy, like these kind of creative solutions.
Where was this?
This is way out in
horses?
Yeah, in Oregon. Didn't end up matching there, but
Dang, sounds fancy as hell.
Look, there are, so I mean, I agree with you. More patients screened hypothetically could lead to more patients on drugs. And yes, there is a financial motive. A lot of these medicines used in the pediatric population, scarily enough, might help with depression sometimes, but also one of the risk factors, the black box warnings on these medicines, is increased suicidal thoughts. So it's like, what are we doing here?
That's scary, right?
Right, it's extremely scary.
That's scary.
It's why would we help someone or try to help someone with their depression, but hypothetically maybe increase or worsen their suicidal thoughts at the same time? Now, bringing up a different industry that I would argue is definitely evil as well in some regard. I think I would theorize that the increase in the mental health damage of this patient population is social media. So I think social media should actually be the one paying for screening, arguably maybe even paying for the treatment, getting these patients involved with professional mental health workers like you and me, and of course therapists and those other creative solutions, because I would argue they're a big part of the problem here. The comparison that a lot of patients feel when they log onto Instagram or TikTok or these other things, or they always how the lack of communication skills because they're so addicted to these social media entities. That's my kind of big thing. And that was really what I was alluding to maybe earlier. Like, I think one of the best ways to screen these patients, ages 12 to 18, the best is always not necessarily having someone like me and you talk to them first. Maybe it's that when they're scrolling through Instagram, oh shit, to scroll further, I have to answer these questions about depression.
Would that ever make sense economically? I feel like if somebody sees that, it's gonna just increase their chance that they're gonna click out of whatever they're looking at.
Hmm.
I feel like there's a fundamental conflict with, I mean, because social media is inherently designed to be addictive, right? To capture your attention and to hold your attention.
Right.
So if I had to answer if I'm feeling depressed today to scroll to that next video, click, I'm
Right.
off. I'm moving on to that next platform that won't ask me that question. So it would be incredible if that kind of modality could be implemented across maybe all platforms. But that is a discussion much bigger than what you and I are capable of, right? These are,
Maybe.
well, I guess not the discussion itself, but the potential solutions, right? It's a political one. There's a lot of money involved, and Google, Facebook, Instagram, these companies are, I mean, they've got a lot of money.
Right.
And in this country, money is what makes things happen. So I wonder if that is a potential change that is even feasible. And at the same time, I strongly believe that these modalities, Facebook, social media, they're here to stay. They're not going anywhere, right? So these issues with comparison, some of the anxiety, depression associated with social media use, these are problems that are going to persist, right?
Mhm.
Not just for the generation of adolescents today, but for the generation that's even unborn that are going to be coming into this world, right? Potentially, they may be facing it at an even harsher degree. So when we're screening for patients with depression at such a young age, one of the concerns that I immediately have is, what is the goal? Is the goal to put somebody on antidepressants? If it is that the best possible way to help these adolescents dealing with some of those dysphoric feelings? Because I strongly believe that you need to prepare somebody for the road ahead. I think in today's culture, we're in this mindset that any sort of depression, any sort of dysphoric feeling is a negative and must be dealt with at all cost. But I don't think all depression needs to be treated. Only if it gets to a certain point and is starting to affect your quality of life, right? If it's having a tangible effect on your quality of life, yes, it should be treated with medication. But at the same time, depression also is a normal part of life. It's a normal part of growing up, right? There's always been, people teasing each other when you're kids, right? But through those experiences, you start to build resiliency. Through those experiences, you start to build empathy for the struggles of other people. So I think to a certain degree, those experiences are kind of necessary. And that's why I'm always hesitant, especially when the first step is just medication. And I think you touched on it a little bit, but I wouldn't mind these screenings. Actually, I would think it's a great idea if what we're promoting is CBT or other therapy-based modalities where we can teach individuals coping mechanisms. I think for a patient that's 12 to 18 years old, rather than giving them a medication, teaching them coping mechanisms that they can utilize even when they're not on medication is the best thing that we can do for them. Because what do we know about antidepressants? It's only effective as long as you're taking them, versus CBT, even things like meditation, yoga, mindfulness. These are skills that you can obtain and they carry on with you for a lifetime. You can utilize them anytime that you want.
Right. Yeah, I mean, I think great points. I would, in some regard, try to defend the United States Preventative Task Force, right? Because I would guarantee further in that because they have all these preventative task force recommendations, right, and guidelines, and you and I both know, and even if you're a therapist out there, like ideally we don't want to start with a medicine first. Ideally we do want to try one of these other modalities. I think sometimes us physicians, prescribers, feel compelled to do something. And, me and you, I wish we actually had more time to spend with patients. I wish that we had more time to provide psychotherapy. The nature of our skill set and our knowledge base with our understanding of medicines, that it seems like a lot of the time when patients end up on our footsteps, a lot of times they really, in a sense, are arguing, begging for some treatment. And at least that's a lot of the parents I've interacted with. They're scared. They're scared that their kid could be that next kid that ends up on that really horrible funeral, right? So that's why I think I still am as pro screening as you can get, because I think it's important to get the input of the parents, of the kids, and also but reaching that patient directly, because there are of course situations where maybe the parent, the teacher could have noticed an abrupt change, but there are definitely other situations too where someone did act really impulsive, or maybe they were able to put on kind of a good game face in a sense. You hear about those like high school quarterbacks, right, who were popular and then they still end up committing suicide. All of these things happen. Mental illness is not specific necessarily to the high school reject or anything like that. Isolation of course factors in here, but I think we do need to kind of collect as much data points as we can. But I'd like to really bring up something else that you kind of talked about is, I do think there's such thing as potentially screening fatigue. Like I was saying, like with Instagram, would that person just be, whatever, I don't care. Like how can we make sure when we do try to screen someone that we're actually getting legitimate responses? Because we even talked about this before the recording. Like, okay, so if this screening is like, I've seen the, there's the PHQ-9 that identifies 9 different questions to identify depression. Isn't there a PHQ-3? Maybe there's some other acronym. There's a three question one that's built into the EMR I use all the time. I forget the stupid acronym. But like how can we get the data we need in as little questions as possible? Because as me and you are seeing, trying to grow this mental health content, we're prevalent on YouTube, Instagram, TikTok. People's attention spans are seconds. So we have to be able to collect this data extremely, extremely quickly, and knowing that person's actually going to give us a legitimate answer. So what I fear is, is this screening going to become something that people don't take serious, that they just click through as quick as possible? Because what I would ideally want to see built into screening is, instead of these necessarily like kind of binary questionnaires, these questionnaires that we fill out on apps on the phone, it's having a legitimate conversation with a mental health professional. Something that you kind of talked about earlier, like, is the screening going to lead to more medications? And I potentially, I'll concede that, right? And I'm okay with that in some situations, right? I think some situations it's inappropriate, some situations it's not inappropriate. But I like to always say there's no side effects for therapy besides your time. So in many ways, I think if someone has mental illness or they don't have mental illness, everyone should meet with a therapist from time to time. I value the service that a therapist can do so much that I really define it as like the oil change. We used the car mechanic in our last episode analogy. Like, I think the therapist is that driving coach helping that person driving the car. I'm the mechanic. I understands really under the hood, the brain physiology. And of course that therapist does too. I'll acknowledge that. But I really think that it's a wonderful service that people should engage with on and off throughout their entire life.
So Logan, perhaps the last time, I spoke, it may have come off as I'm against the screening or I'm against medication. I'm not, right? I just want to be very clear about that. I'm not. I do have some concerns about screening, but I think overall the benefits outweigh the risks.
Right.
I do have concerns that we're a little bit too quick to pull the trigger on putting especially children on medications, especially SSRIs.
Right.
But I also recognize that it's necessary in many cases. The only thing that that really bothers me is sometimes as clinicians, I feel like there's this attitude that when a patient comes in and they're depressed, the only thing we do for them is prescribe them a medication.
Right.
And that's my repulsion right there. I think we need to be more mindful that there's other modalities such as mindfulness, CBT, other one-on-one counseling where you can gain skills that you can carry on with you.
Right.
So that's the first thing. And on the thought of, patients being put on medication, I have some stats for you. So the annual percentage of young people who took antidepressants, a stimulant, or an antipsychotic. So for age groups 3 to 5, it was 0.8% of the population. For ages 6 to 12, it was 5.4% of the general population. Age group 13 to 18, 7.7% of the population. So I don't know what your reaction is. Some of you listening might be like, oh my God, that's so high. Some of you listening might be like, oh my God, that's like not high enough. So initially I had thought, wow, that's like almost 10% of people age, 13 to 18 that are on SSRI or a different psychiatric medication. However, when we looked further at the prescription rates compared to the diagnosis rates, it kind of paints a different story. You kind of start to get the more full, the more comprehensive, and the truth starts to come out. So for example, about 1 in 8 teens experience depression each year, but less than 1 in 30 were prescribed antidepressants.
Okay.
About 1 in 12 children have symptoms of ADHD each year, but only 1 in 20 received a stimulant.
Okay.
So, in fact, children in the United States may be under-medicated. That kind of terminology sounds a little bit off-putting, but I guess, what it really means is that there's a lot of patients out there that could potentially benefit from being on a medication that have been diagnosed with the pathology, however, are not actively being treated for it. And you have to wonder what kind of even economic costs that's causing to our society, right? I talked about earlier, at an age demographic of 12 to 18, untreated depression could mean the difference between going to college and not going to college. It could mean the difference between, being able to marry later on in life, having a stable family life, versus having no relationship, falling into substance abuse. So it can have dramatic downstream effects. So what is the potential downward stream effects of not treating people who need to be treated? So that will be the main argument, right? And the strongest argument that we have, that these screenings are necessary and medications are absolutely necessary for children today.
Right. And, that's, of course, just specifically to medicines. And, I think where me and you come from is, I think us mental health prescribers are, in a sense, frustrated with antidepressants at times. They can be helpful. They have helped our patients. We know the data around them, but they take a long time to work. They hypothetically can increase suicidal thoughts, especially in the pediatric population. But I also like to remain as optimistic as possible. One thing that got me actually into medicine as opposed to therapy is, what is the new role and innovation of psychiatry? Is there going to be more drastic interventions that we can do immediately to try to get someone out of depression in maybe a few hours, rather than over taking this pill every single day for 4 to 6 weeks, and then we'll know if it's actually having an effect or not? Is there a role of transcranial magnetic stimulation more in the pediatric realm? Is there a role of even ketamine or these other modalities that are now just trying and just starting to kind of get some traction in this nation? Who knows? I'm optimistic, I'm curious, I'm skeptical, all in the same regard. But I think I just want to stress, like, kind of what we said earlier, like, the number one killer of this patient population, ages, what did you quote? It was 12 to 18,
Mm-hmm.
is suicide. we have to be as aggressive as possible. And so I know some parents definitely can feel, and maybe some teachers like, oh, you're giving me more work to do. Oh, now the teacher or maybe that parent does have that kind of gut reaction like, oh, this is just the farm industry trying to get my kid on pills, all these things. But I think it's society's answer to try to avoid this dire situation that we find ourselves in where our kids are dying from suicide.
So, one last comment I have about the benefits of screening. I think I started out this conversation more, portraying myself as being against these screenings, but hey, that was just for conversation.
All right.
Just trying to facilitate this podcast episode.
Absolutely.
But in reality, I do truly believe that there's a lot of benefits. And I want to talk about a point that's near and dear to my heart. So one of the big issues in the world of healthcare today is healthcare inequities, right?
Mm-hmm.
So I think this is one great way, these screening for depression in high schools, junior high schools, can be a great way to address healthcare disparities. Here's what I mean. So I grew up in an immigrant community. I have friends whose parents my best friend is from Afghanistan. His father was an Afghanistan war refugee. My own parents immigrated to this country after the 1998 financial crisis in Asia. They lost all their financial savings. They came over here to start a new life. They didn't know the language. They just came here and did everything that they could to put together a life, right? And I had a lot of friends who grew up under the similar circumstances as me. And having parents who's gone through that level of difficulty, sometimes you feel ashamed to tell them that you're depressed, that you're feeling anxious. When you feel like, objectively speaking, your life is so much more calm, so much more safe than what our parents went through. So there's this element of shame that may exist that may potentially make it more difficult for children growing up in underserved communities to share some of those concerns. So that's one. And two, for children in those kind of underserved communities, one of the big issues is that there's a cultural barrier. Our parents are immigrants. They didn't go to the school system here. They don't understand what it's like to attend school in the United States. They grew up in a vastly different culture. They don't understand the nuances of what we go through on a daily basis. So there's that fundamental disconnect. And a lot of the times we feel like if we even share our experiences, they're not coming from a background where they're able to relate and empathize. So that's one barrier. And an even bigger barrier is, look, my first language was Korean, right? But I'm much more fluent in English. In fact, when I speak Korean now, I feel like a totally different person. So there's undeniably a language barrier, right? Language is an expression of who you are as a person. And limitations on language can make you feel like you're not the same person. And many of us growing up in immigrant communities, we're not able to have that level of nuanced discussion with our parents who oftentimes don't speak English. So potentially the screening modality implemented in schools can be a solution to that barrier.
Right. I think that's great points, and it's pretty fair to conclude in some regard that, people from different racial backgrounds can engage with the mental health system to a lesser degree. They still suffer from mental illness at the same rate, but whether that's from socioeconomic reasons, not having the money to access these kind of programs, or like you said, kind of the cultural aspects. I also think what's kind of important is maybe the generational aspects too. We've done previous episodes, check them out because they're amazing. But on like hustle culture, you talked about what high school in Korea is like dealing with, what was it called again? Hagwon?
Hagwon, yep.
And I think this is anecdotal, but high school these days is a lot harder and more stressful than it was 40 years ago, right? So the stressors and the different factors that these kids have to go through is different. Then you add on to the fact that they didn't go to school roughly for what? A year and a half, or depending on where you lived, right? Like they engaged with, tele school because of COVID. These kids have had it really, really rough. So I think that we need to make that kind of important distinction, that I wonder if some of the resistance to the screening comes from a generation that still, of course, dealt with mental illness, but, they went through a different sort of high school. They had jobs that they could actually afford to buy a home reasonably after high school, right? How can that even happen in today's world? Like barely. not at all, unless you have some, inherited wealth kind of thing. So I think all of those factors are really important to highlight here: the socioeconomic, the cultural, and even the generational changes that our patient population, these kids, deal with today.
Big changes are inherently very uncomfortable.
Mhm.
And I completely understand that there's a lot of people out there that are concerned about this push to screen for depression in patients 12 to 18 within our school system. I have tried my best to argue some of those concerns, and hopefully we did a good job of presenting both points of the argument, because it is a true fact that this is something that's still being debated. There's legitimate arguments on both sides, but I think at the end of the day, where I fall on that argument is we have to remember that there are potential benefits, and just like when we see patients, we're always weighing the risks of benefits versus the harm.
Right.
And in this case, I have to say there are undeniably a lot of benefits for this kind of screening modality to be implemented in our school systems. So unless you got anything else, I think we should wrap it up there, Logan.
Cheers.
If you made it this far into this episode, please make sure you follow the podcast. And if there's one thing that we can ask from you is please share this episode with your friends and family. That's the best way to help out this podcast, help us grow, and show your support, and to help us keep going to produce this great content for you guys.
All right. Have a good night.